I want to welcome all of you and thank you for spending your night with us tonight. I'm Jacqueline French, and I am the current secretary of the American Brain Foundation. And we are here tonight with an amazing two individuals who know a lot about seizures to talk about seizures, which are a complex neurologic phenomenon, which, as I'm sure many of you know on this call, can be very frightening and are often very misunderstood. So hopefully tonight we will learn more about them and they will not be as misunderstood. We're going to try and demystify a few things, provide valuable insights, and foster a deeper understanding of the challenges of individuals who are living currently with seizure disorders. Webinars like this one tonight are opportunities that we have at the American Brain Foundation to connect you with experts on various topics of interest related to the brain. And I invite you all to be very active during this evening's conversation. And if you have questions, please put them in the chat at any time. After the presentation, we will get to questions and we'll try to address as many questions as we possibly can. The American Brain Foundation funds research across the spectrum of the brain because we know that brain diseases, disorders, and injuries are all interconnected, and our byline is cure one, cure many. If we understand what underlies certain conditions, then we will start to understand also what underlies others. In terms of epilepsy, we're currently funding 2 epilepsy researchers. The topics of their investigations include looking at potentially shortening clinical trials so that we can bring new therapies to the clinic faster, especially for participants who are not responding. And this also allows subjects in trials not to remain on blinded treatment for as long. And we're also funding a project on the role of the microbiome in drug-resistant epilepsy, which is an extremely hot topic, which can lead to new therapies. And in the last 10 years, we've granted over $1 million to epilepsy research, and we will certainly be providing more investment in epilepsy research in the future. Which leads me to say that we can't do our work and improve the lives of people with epilepsy and other brain diseases without the support of our donors. So if you are enjoying this, if you're learning something, and if you're so moved, please make a donation so that we can continue funding critical research and continue to host webinars like the one we're doing tonight. You can give at americanbrainfoundation.org/donate or scan the QR code that is on your screen. And before we move into the panel and the questions and answers, I have enormous pleasure in welcoming the brand new executive director of the American Brain Foundation, who is Michelle Heritage. Michelle has contributed more than 30 years of nonprofit and public sector experience and leadership roles across multiple industries, and we are absolutely thrilled to have her at the helm at the American Brain Foundation as it broadens its footprint in our efforts to advance brain disease research. And I know that she would like to say a few words. So Michelle, take it away.
Well, thank you for that wonderful introduction. I'm absolutely thrilled to be the new leader of the American Brain Foundation. Such an incredible mission. What really moves me is our idea that by curing one, we can cure many. And the medical research can make it possible for us to be able to get at more than one cure by finding one. So really thrilled about the work that we're doing, thrilled to be part of the American Brain Foundation, and want to welcome everybody tonight and say thank you for coming. I think it's going to be an incredible panel. And Dr. French, I'll turn it back over to you.
Thank you. And now it is my great pleasure to introduce our 2 panelists tonight. The first is Greg Cascino, who I've known for more years than he or I probably want to admit to. He is currently the Whitney McMillan Jr. Professor of Neuroscience at the Mayo Clinic College of Medicine and Enterprise Director of Epilepsy at the Mayo Clinic in Rochester. And in a minute, we're going to ask both of them to tell us a little more about themselves and what brings them to the field of epilepsy. And our second panelist tonight is very connected to the American Brain Foundation, Alyx Porter. She is a neuro-oncologist and associate professor of neurology at the Mayo Clinic also, but in Arizona, director of the neuro-oncology section, and former co-chair of the Central Nervous System Disease Group for Mayo Clinic Comprehensive Cancer Center. So thank you so much, Drs. Porter and Cascino, for taking the time to join us tonight. And let's just start the panel discussion by having each of you briefly just talk a little bit about yourselves and your connection to the American Brain Foundation, if relevant, and your connection to people with epilepsy. So, Dr. Cascino, we'll start with you.
So, Jackie and the others, thank you very much for your kind invitation. And there's no more important role than the American Brain Foundation. And I've been a member of the American Academy of Neurology for now over 40 years and had the pleasure of serving on the board of directors and chair the Member Engagement Committee, a professional organization that works very closely with the main American Brain Foundation. My background has been in internal medicine, neurology, and then subsequently in epilepsy. And I always remind myself that the care and management of patients with seizures goes beyond rendering them seizure-free, but allow these individuals to become participating and productive members of our society. Our goal should always be seizure-free, no adverse effects associated with therapy, and improvement in quality of life. And that remains a mainstay of my professional training and my clinical practice. We know epilepsy is a very common disease. Perhaps 1 in 26 Americans will develop a seizure disorder during their lifetime. A significant number, as we'll hear, have drug-resistant epilepsy that may be medically, physically, and socially disabling. So this is a great opportunity, a great challenge to improve the quality of lives of these individuals. So thank you for allowing me to participate.
Thank you for being here. And I forgot to mention that I also treat people with epilepsy. I've been an epileptologist for 30 years, which makes it even more exciting for me to talk to our two panelists. Dr. Porter, can you introduce yourself a little bit?
Absolutely. Thank you so much for having me this evening. As you heard, my name is Dr. Alyx Porter. I am a neuro-oncologist, which means that I have the privilege of caring for patients who have brain tumors. So most commonly, there will be tumors that can arise in the brain itself, but also I take care of patients who have tumors elsewhere in the central or peripheral nervous system, and also those patients who might have neurologic complications from their systemic cancer treatment. And so while I'm not an epileptologist or an epilepsy specialist, I consider myself very epilepsy adjacent because many of the patients that I have the privilege of caring for have experienced a seizure at one time or another. For many patients, a seizure may be the first indicator of the presence of a brain tumor. And we know for patients that are experiencing cancer-directed therapy, sometimes a seizure can be a side effect of that therapy. And so it's just been a pleasure for me to be part of not only the American Academy of Neurology, but to have joined the executive board of the American Brain Foundation. And I'm pleased to have served on the board of directors of the American Brain Foundation for the last few years. And so I'm just grateful for the honor to spend a little time with all of you tonight and look forward to the discussion.
Thank you. That's fantastic. So I'm going to start with a question which you partially answered already, Dr. Porter. So I'm going to turn to Dr. Cascino and ask, what are some of the common causes of seizures that you see?
So it really depends a lot on the age group, as you know it, for the age at onset and the type of seizure disorder. My practice is largely adolescent and above, so adults. We certainly have a number of patients, maybe 1/3, who may have a symptomatic lesion in the brain causing their seizures: tumors, stroke, blood vessel malformation, traumatic brain injury, focal cortical dysplasia. Not an insignificant number, which is why anatomical studies like MRI are essential in many of these patients at seizure onset. Unfortunately, a significant number do not have an obvious etiology or cause based on the neurologic history and the initial evaluation. That does not mean they do not have a focal pathology. They still may have drug-resistant seizures and require additional medical and surgical care. But it's quite, I think, disappointing to the families when they hear, we don't know why you have seizures, but we know the seizures cannot be easily controlled, and we'd like to look at alternative forms of therapy. And that's oftentimes even patients who are physicians have a difficult time with that. Increasingly, we're finding that a number of these patients may have genetic etiologies. Not uncommonly, you may have a genetic epilepsy in the absence of a positive family history. So the fact that no relative has seizures does not mean that it may not have a genetic etiology. And we now know that a number of autoimmune neurologic diseases may be associated with focal and generalized seizures. And these patients may respond to different types of therapy, such as immunomodulating treatment and not anti-seizure medication. So we've been working very closely in a number of patients with autoimmune and genetic experts to try to get some information on etiology. And then finally, there's an important cohort, and this is one we deal with very commonly in our surgical epilepsy practice, who probably has focal cortical dysplasia or a malformation of cortical development, and the imaging studies do not show an obvious abnormality. And these patients may go on to have different types of treatment, and surgical pathology may reveal the focal cortical dysplasia. So there's a number of causes. I think the history is always important. A remote history of complex febrile seizure in childhood, meningoencephalitis, is an important etiology for many patients. And then in concert with the neurologic history, I typically do some type of anatomical imaging studies such as MRI, and we may need to do additional laboratory studies, especially increasingly autoimmune and genetic etiologies, looking for a cause for their seizure disorder. But you still need to treat the patient even if you don't know the cause. So you don't want to waste too much time on looking for the etiology, because ultimately what you'd like to do is reduce their seizure burden and improve their quality of life.
Yeah, thank you. That was very well stated. I still remember the first episode of Grey's Anatomy, by the way, when the neurosurgeon comes charging in and says, "This young lady just had a seizure and I don't know what caused it. And if I can't figure it out, she's going to die."
Right.
And I was like, oh no, that is not true.
So I would say if we walk out of the room, initially when I see a patient in an epilepsy clinic, about 2/3 of the time, I can scratch whatever remaining hair I have on my head. I don't know the cause. About 2/3. Now, some of those will find a cause based on the evaluation or subsequent studies, but that's not uncommon. And that should not, I think, delay the evaluation and treatment of these patients.
Yeah, and interestingly enough, it also does not lead to some people responding to therapy and others not. It really doesn't matter whether there's a cause in regards to how likely it is that we can control the seizures. The difference, which we'll get to, I think, a little later, is only whether if the seizures don't respond to therapy, somebody might be a candidate for a type of surgery.
Mm-hmm.
And Dr. Cascino, if you could just tell the audience members, particularly the lay members who don't know what a cortical dysplasia is, if you could just go into that a little bit.
So I kind of think of that as being a birthmark. It's something that probably develops very early as the brain is being formed in the first trimester of the pregnancy. Many times these individuals are normal at birth. They may have an abnormality in the brain that may be localized, hence the term focal. And their only clinical symptom in some cases may be seizure activity. And if you look at patients early in life, such as in the first 2 decades, it's probably one of the more common causes for treatment-resistant epilepsy. And the epileptogenic neurons, that is the nerves that cause the seizures, are intimately associated with the abnormality that we see, hence the birthmark. And imaging is probably very good in about 80% plus of these patients, but not 100%. And many times they can present with drug-resistant epilepsy, undergo a comprehensive evaluation, which is disclosed as a relationship or a concordance between the area of seizure onset and the focal pathology. And that's really important because a number of these children and adolescents and young adults can have very difficult to control seizures. I can't emphasize enough, you've got to stop the seizures, or at least try. Because although these are transient and relatively benign problems in many patients, we do know that a significant number may have a potentially fatal disease. And sudden unexplained death in epilepsy is an important concern from 0 to 100, including in children and adolescents. An important marker of that is that these patients have seizures that are difficult to control. So part of our treatment is not only to reduce seizure activity, improving quality of life, but I think in many of these patients it's extremely important that we try to reduce the risk of sudden death. And I don't think that's emphasized enough by physicians because they're uncomfortable talking with patients about this type of neurologic catastrophe in some individuals.
So we're going to get back to sudden death in a minute, but actually I'm going to roll it back a little bit and just ask you to tell me, I think Dr. Cascino, and if you have anything to add, Dr. Porter, what is epilepsy and what is a seizure and what's the difference between the two? A lot of people will say, oh my goodness, I have seizures and I have epilepsy. I must be very, very unlucky. So maybe
So it's unfortunate that there's too many terms here, and that's probably the trouble. Seizure is the clinical event, and I think of a seizure disorder as typically being an increased tendency for seizures, typically a 60% greater chance of having the next seizure. So individuals who have a seizure disorder or epilepsy, which are synonymous, oftentimes will have 2 or more unprovoked seizures. However, there are individuals who have a single seizure where we think the likelihood of recurrence is sufficiently high, 60% or greater, that the evaluation and treatment is conducted very similar to those who have a seizure disorder. So we try to differentiate between, is it a provoked event, i.e. with alcohol withdrawal, some medication intoxication that causes a seizure, might be different than a patient who has an unprovoked seizure. But most people who we see with a seizure disorder have recurrent and unprovoked seizures. But there now are individuals who have a single seizure where I think of 60% as being a good number, because if they have a 60% greater chance of having a seizure, even after a single event, we many times will conduct an evaluation and look at therapy in those patients because we're concerned about seizure recurrence. If a person has a single unprovoked seizure as an adult, your likelihood of a seizure recurrence is as high as 40 to 50%. So even a person who has a single seizure deserves an appropriate evaluation, which does not necessarily obligate them to use anti-seizure medication. But the term seizure disorder and epilepsy should be synonymous, and seizures are part of the illness, kind of like seizures are the jigsaw puzzle. They're one piece of the puzzle, and seizure disorder is the constellation of the puzzle itself. So it's a medical condition. It's one of the most common chronic neurologic disorders, and oftentimes cared for by non-neurologists as well.
Thank you. I'm going to turn to Dr. Porter. Dr. Porter, can you explain the relationship between brain tumors and seizures? And maybe you want to just comment on the fact, I think I understood that people who present with a seizure actually may have a better prognosis than people who don't. And what considerations might arise at the intersection of cancer treatment and seizure management?
Yeah, thank you for that question. And really building on what Dr. Cascino mentioned about the jigsaw puzzle, the seizure in my world oftentimes is a symptom. And so that would be a situation where the seizure was provoked, oftentimes by a mass lesion. Sometimes that mass is malignant, sometimes the mass is benign. And so it really does depend on where in the brain the mass arises as to whether or not a patient may present with a seizure or may experience seizures as part of their experience as far as their treatment. I would say that, and Dr. French, you asked me a couple of questions at the same time, so I'll try to break down. I think one of the things that you asked was about in relation to treatment. There are some patients who have brain tumors who never experience a seizure in their entire experience. And the data would suggest that for those patients, there's no benefit of being on any kind of anti-seizure treatment. There's no literature that would support that starting a medication in a situation where you've never had a seizure actually prevents a seizure from happening. So in my world as a neuro-oncologist, when I meet a patient who has presented with a seizure, because that mass lesion is there, and we believe oftentimes that it's the source, that's when we start to look at, okay, is it time to treat this seizure? What is the next step? Does the patient need some sort of brain surgery to try to remove what's provoking the seizure? And the question that Dr. French asks about whether having a seizure as a presenting symptom ends up being a better prognostic sign, it really can vary. So there are some tumors that are closer to the cortex or the surface of the brain. And those tumors, when we're thinking about benign and malignant, on the malignant spectrum of things, those tumors tend to be oligodendrogliomas. And we tend to see those patients with that type of tumor present at a younger age, and seizure might be the initial symptom they experience. One of the things that was wonderful in 2023, moving into 2024, is we finally have a new drug for patients with IDH mutated tumors. And that's a common mutation that's found in oligodendroglioma, where we're able to treat patients who have these tumors, give them a medicine, and try to hold off on surgery and radiation and chemotherapy for as long as we can. And so that tumor itself, the oligodendroglioma tumor, tends to have a better prognosis compared to an astrocytoma. And so we know if patients have a seizure and have a tumor that's much deeper or more extensive, where oligodendroglioma tumors tend to be fairly well circumscribed sometimes they may look calcified because they've been very slow growing. Astrocytomas have a different appearance with finger-like extensions. Those tumors are much more difficult to treat. And so when a patient presents with seizures and an astrocytoma, oftentimes that treatment becomes much more complex. And so the approach may be a bit different. Dr. French, did I capture all the questions that you asked?
One more question to go along with that, and that is the issues that may arise if somebody is getting chemotherapy and getting epilepsy therapy at the same time.
Yes, that's where the term that some of you might be familiar with is called polypharmacy. And that's when people are on multiple medications. And we have to be really conscientious because there are some medications that speed up the metabolism of different drugs. And there are some medications that decrease the metabolism of certain drugs. And so that can make it very difficult to titrate or to manage either of the medicines, but in particular, some of the anti-epileptic drugs. And so that can very much be a challenge, and why it's critically important in my oncology world to have an understanding. There's so many new cancer-directed therapies now, and it's critically important that I stay on top of the literature to be aware of the mechanism of action to make sure that the patients remain safe. And if they have had seizures as part of their experience, that they remain under great control. And I did want to take a moment, I see the question in the chat, is astrocytoma a cancer? The answer to that is yes. There are low-grade astrocytomas and high-grade astrocytomas. Low-grade astrocytomas are still cancer. They're just a slowly growing cancer, where we've not yet been able to use the word cure. High-grade astrocytoma is much more aggressive cancer. And those are the high-grade astrocytomas are the ones that the tumor types or the cancer types that we tend to hear more about in the news and garner a lot of attention because of the extremely difficult prognosis that's associated with them.
Thank you. That was very comprehensive. So we know that fortunately, 2/3 of the time when somebody develops seizures and a seizure disorder, their seizures can be very well taken care of by any of a number of what we now call anti-seizure medicines. You may have heard the term anti-epileptic drug, but we don't use that term anymore because these drugs do not actually treat the underlying disease. They treat, as Dr. Porter was talking about, the symptom, and the symptom is the seizure. The underlying disorder, as Dr. Cascino said, is any of the number of things that can cause electrical disturbance in the brain and produce seizures, and anti-seizure medications treat that. Unfortunately, that does mean that you need to take those medications on a recurring basis every day, but fortunately, 2/3 of the time, that does control all the seizures, and an individual can go about their life as they had before. But Dr. Cascino, for those who don't respond to seizure medication, what alternative treatment options are available when those anti-seizure medications are ineffective?
So that's an excellent question. And this is a very common issue in comprehensive epilepsy centers like Dr. French and I both participate at. So we have 1/3 of the patients, you say, who have drug-resistant seizures. And that can be defined as 2 or more anti-seizure medications that are ineffective if appropriately used. So you can make a definition of drug-resistant epilepsy, perhaps even early in treatment. When we looked specifically at our institution, those who are undergoing comprehensive epilepsy evaluations for treatment-resistant epilepsy, many of them had seizures for 15 to 20 years on average. Way too long, because no seizures, no side effects, no lifestyle limitations. That's our goals. and drive a car and get on with your education and your employment. And to do that, you oftentimes have to have a significant reduction in seizure tendency. So oftentimes we'll pause initially when we hear the story of the medicine doesn't work. I'm still having seizures. You can't replace doing a neurologic history in the office. Was medicine used appropriately? Do we have the right seizure classification and the seizure type? To some extent, you have to match the medication with the seizure type the patient has. Where there are other confounding variables that were increasing seizure tendency, lack of compliance, lack of medication adherence, etc. And then in many cases, I think we have to say, okay, now what can we do to try to reduce seizure tendency, reduce the risk of sudden unexplained death and epilepsy, improve quality of life in these individuals? And many times what we'll do at our institution and many others is we make sure they've had a high resolution MRI head epilepsy protocol to minimize any possibility that there's a lesional pathology that was missed. One of the chat questions was 7 Tesla, which we use at our institution in patients who have MRI negative epilepsy. Probably helps a small percentage, maybe 10 to 20%. Most of them have had some type of focal cortical dysplasia. If the 3 Tesla study was normal, 3 Tesla is more than satisfactory for most patients. And then we'll bring them in our epilepsy monitoring unit in many instances to record their typical seizures. What type of seizure they have? What is the surgical localization? Are there additional imaging studies that they need? And there's several treatment options. Actually, at this point, there's more options than we would like to consider because we don't know what's best for that individual patient. It might be continued anti-seizure medication trials. That may be the correct answer. It might be some type of destructive procedure. And now we look at focal cortical resection and laser ablation, which are used very commonly at surgical epilepsy centers, depending on the needs of the patient, area of seizure onset, likely surgical pathology. We may look at neuromodulation, and neuromodulation, when I was a resident, didn't exist. In 1997, vagus nerve stimulation was approved by the FDA, and now we have 3 FDA-approved devices, and most centers, including ours, are doing some type of investigational procedure that being used. But in many instances, to be seizure-free, some surgical procedure is likely to be the best chance for that individual patient. What I find very helpful, though, is we pause after our evaluation and we have some type of conference with our healthcare professionals, review all the totality of the patient's clinical problems, their neuropsychological history, what other medical issues they have, what their goals are. And patients come in many times with different aspirations about being seizure-free versus medication side effects, and try to match what the best option is for that individual patient, counsel and guide them, and work very closely with our neurosurgical colleagues. But I think in those 1/3, the last thing we should do is just immerse them in polypharmacy, continued seizures, hoping the next combination may help, and go years with refractory seizures. Because in many cases like that, they're unlikely to be seizure-free. And now they have a new problem, anti-seizure medication adverse effects, compounding what's been a treatment-resistant seizure disorder. Long answer, but I think it's a complicated group of patients that should be very carefully identified and treated.
Thank you. You had mentioned sudden unexplained death, so I don't want to over alarm or under alarm. And by the way, in New York, the state of New York now, it is a state law that all physicians who care for people with epilepsy need to advise them that sudden unexplained death may occur. So that is a state law. People are starting to understand that it is an important part of the communication with a person about their seizure disorder. But Dr. Cascino, can you just tell us a little bit about what the likelihood is, why it happens, and what the likelihood is that it happens?
So in terms of the number of patients on an existing basis, it's relatively low, maybe 1 in 1,000 patients. But if you look at it in terms of age-matched controls for sudden death in these patients, it's significantly higher. And Dr. Davinsky, Dr. French's colleague, has really, I think, caused a lot of attention to this, is the fact that patients can have sudden death who have generalized or focal seizures, may have seizure disorders that may be appropriately managed and treated by physicians. Not uncommonly, they'll have nocturnal, tonic-clonic seizures. They may have drug noncompliance. They may have prolonged seizures. And most of us who treat patients probably have 1 to 2 of these adverse experiences each year where we'll get a call in the morning that someone sent an email in that their son, their daughter, their husband, their wife passed away. And they don't have to be developmentally delayed. They don't have to have severe intractable epilepsy. we give a pamphlet to all of our patients and the initial educational material that outlines some information on it.
Do I want to sleep?
From us than hear from
No.
someone else.
No, that's fine.
I think we have somebody else's on mic. But better hear from professionals than get wrong information. And then put it in the totality of it, uncommon, and an important reason why I want the seizures to be treated. I also use rescue medication. And it amazes me how many patients have never heard of a rescue medication who I treat. And I remind them that one of the State Farm people came to my house and they nixed me on my auto insurance because they said I didn't have a fire extinguisher in my kitchen. I said, I've never had a fire. They said, but you could have a fire and you need a fire extinguisher. It's real simple. So if you have a seizure disorder, I think especially one where you're concerned about a life-threatening type of seizure, there should be a seizure emergency plan, and that often will include a rescue medication. And by the time in many of the communities that I treat patients with in rural areas of the upper Midwest, it may be 45 minutes to an hour before anyone's going to arrive to see the patient, let alone take them to a hospital to get treated with an intravenous medication, when we have the ability for them to use medication in the bedside, in the home, in the crib. So these are simple things that we have to think about that oftentimes we neglect when we see patients.
Yeah, absolutely. I completely agree. And by the way, when we're talking about rescue medicines, we're usually talking about what we call a benzodiazepine, which is a Valium-like drug that can either be administered in the nose or can be administered in the mucous membrane of the mouth. So it used to be that the only way to administer it was rectally, which was not as much fun. But fortunately, now we have a much easier ways to administer it. And I completely agree. Rescue medication is an important part of the therapy required to make sure everybody stays safe, and also to, take away some of that helplessness that people feel when they see their loved one having a seizure. I mean, I often say that I want to open a post-traumatic stress disorder clinic for spouses or parents who see their loved ones have a seizure, because it looks like that person is dying right in front of you, and you have an enormous feeling of helplessness. And just having something to do, have a medication that you can spray in the nose, for example, not only keeps the person safer, but, gives that sense, I can do something.
I completely agree. Yeah.
And I also wanted to just change gears a little bit and say, talk a little bit about the diagnosis of epilepsy, which is also very problematic. You talked about the very long delay before individuals make it to an evaluation for, let's say, epilepsy surgery, which could render them seizure-free. Can you talk a little bit about the diagnostic odyssey, Dr. Porter or Dr. Cascino, before somebody gets diagnosed with epilepsy? And Dr. Porter, I will never forget the woman who came to me who was having focal impaired aware seizures, which are seizures that, as the name implies, cause you to have an alteration of awareness and confusion. And she had been to multiple doctors who told her that it was women's issues. And when she started to have urinary incontinence during these events, they sent her to a urologist because she was having women's issues. And when she finally got diagnosed, when someone finally gave her an imaging study, she had a large tumor. So that was a diagnostic odyssey that was very, very unfortunate at the end. And I don't know if you've had experiences like that, but perhaps either of you can discuss that.
Yeah, I have. And one of the things that can really be a challenge is that what we see in the media or, on TV, in movies, when we hear seizure, we tend to think convulsion. And so people are quick to name that when they see that. But what becomes a lot more challenging is sometimes people can have convulsions for other reasons that aren't seizures. Sometimes people can have seizures and you may not even know they're having them. Perhaps they could just be staring off. I've had a patient recently who was having a foul smell. He smelled like something was burning. And it wasn't until several months later that he had a large benign brain tumor called a meningioma. But it took several months. He started with an ear, nose, and throat doctor trying to figure out why he was having these foul smells. And they went down a sinus route to try to figure out what was happening with him. And so it's important to be aware that there are many different, what we call seizure phenotypes. The seizures can look different ways, ranging from not witnessing anything that seems abnormal to, as I mentioned, foul smells. Sometimes there might be tingling sensations. Sometimes people might have difficulty getting the words out. There are all kinds of presentations, and that's why, as Dr. Cascino mentioned previously and Dr. French mentioned, having that really detailed history of what the patient's experience has been to try to put some of this together can be helpful as we look to really tailor what the workup should be. And I remember being taught 20 years ago now when I was in training that if you haven't figured out what's going on with a patient by the time you're done talking to them, the likelihood that you're going to figure it out from their examination is not going to necessarily help you as much. And so it's critically important and that the doctor takes their time and really teases out. And sometimes it can feel like scrutiny. But we know that neurologists are some of the best history takers. And so that's why it's important and why if you experience care by a neurologist, we're really going to try to pin down what you were feeling and what happened before and what happened after so that we can help direct how we might be able to best figure out what the next best step would be.
Yeah,
Just to agree with Dr. Porter, I thought that was an excellent remark that she made. One of the problems we have in medicine is we've gotten so big on tests that we stopped listening. And we're really big on tests. So patients will come in with a neurologic history that may be compatible with seizure disorder, but listening for a long time is now not very cost effective. So we'll order an EEG. Well, the problem is an EEG may be normal up to 50% of patients in the first study, and 2 EEGs may be normal. So I saw a patient who always comes to mind about why it's important to do more than just test. EEG, MRI, CT were normal. Blood work was normal. Exam was normal. Farmer, great guy, never did anything wrong his entire life. He put a dash camera on his TV, on his car for whatever reason. So he's driving a car. I guess he does this just to have his dash camera there. And he has one of these events while he's driving. His routine EEGs were normal, so his doctors told him, you don't have epilepsy. You don't have to worry about that. And your EKG is normal, so we'll just sit and watch you. So he keeps on driving, and he drives off the road during one of these spells and has a very clear focal impaired awareness seizure that we nicely recorded by his dash camera. Luckily, neither him nor his spouse were injured or killed, and the car went off into some cornfield. But it points out that tests are important, but it's only one part of it. It's got to be the continuity of the history and then putting together the pieces of the puzzle. And so much in the test right now, a normal routine EEG, a normal ambulatory EEG without neurologic symptoms does not necessarily exclude the diagnosis of epilepsy. And in some patients, I think when we're very concerned about the diagnosis, we should be doing more, I think, what we're starting to do now, which is in-home video EEG monitoring. We've become very aggressive with this at our institution because patients say, I only have spells when I'm in the kitchen, or when I'm talking to my mother-in-law in the bathroom or something. And now you can recreate that with several days of monitoring, up to 1 week, high-quality video EEG. You review it at a comprehensive epilepsy center. I've also been doing a lot of smartphone and tablet sort of video recording. Patients say, John has a spell, lasts 2 to 3 minutes, but has them once a month. We can't do it in the monitoring unit. Go ahead and record the event, and we upload it through the patient portal. And we did a study, and we found about 80% of the time, if you bring those patients in unit, you can correctly identify epilepsy versus not epilepsy. You may not be able to tell if it's right frontal or right temporal, but they shouldn't be driving a car through a cornfield. And I think we really have to be cautious about over-reliance on these routine EEG recordings. A lot of patients, especially in the age group that we see in adult neurology, have mild abnormalities on their EEG that are not of clinical significance or don't point to the diagnosis of epilepsy. They get put on an anti-seizure medication when the history is headache, dizziness, lightheadedness, tired. That's not a seizure disorder because the EEG shows some mild abnormality. Then the EEG is normal. They decide, well, they probably don't have epilepsy. Well, actually, the history is very compelling for a seizure disorder. So you really got to do more than just do a test. And that's a hard part now because so often we want to get busy ordering tests on these epics and so forth. Just a thought of mine.
So we use a phrase recently, the 5 S's: short, sudden, strange, sometimes strange, similar spells. If people have short, sudden, sometimes strange, similar spells, then one has to think about epilepsy. I want to get to the questions, some of which are very good. So the first question is by Maureen. Once a person's seizures are managed and controlled by medication, will they remain on medication all their life, or is there a point where they can safely and gradually discontinue the medication?
Well, I'll take that because it's a common question I get in epilepsy clinic. It really depends on so many factors. The type of seizure disorder the patient has, the age of the patient at onset, the presence of comorbidity conditions such as remote symptomatic neurologic disease, what type of seizures they had before they came under control, and what combination or what medicine they're on, and to some extent, what the EEG pattern shows. So it varies a great deal. But if I see a patient who's had 1 or 2 clinical events consistent with seizures, and the neurologic evaluation is unremarkable, and they've been seizure-free for a period of time, and I tend to be very conservative because I want to allow our patients to do normal activity like drive legally and safely, let's say 2 to 5 years, and there's a compelling reason. They're interested in pregnancy, they're concerned about teratogenesis, they're having adverse effects, etc. Oh, there's a comorbid condition and the pharmacokinetic interaction makes it hard to use that medicine. Then I counsel the patient and guide them. The risk of recurrence is probably low either way. And then oftentimes the patient will influence our decision making over a period of time, reducing one medicine at a time. But it needs to be a discussion you have with the patient, because in some people, this sounds a little bit like my father, who was a surgeon, it's probably better to leave well enough alone. You'll see somebody who's had an episode of status epilepticus, they had a prolonged seizure, they lost their driver's license, they don't have an etiology or cause for the seizure, but boy, they're doing great since they started drug X, Y, or Z, and everything's just perfect. Then I need some compelling reason why to make a change. And there's nothing harm if they're seizure-free, not having adverse effect of the medicine, and doing well. Then sometimes I'll say, let's get to know you a little bit to see what our relationship is and see if there's a benefit to coming off the product. But I tend to be very cautious in those discussions, and probably a little bit more of a conservative neurologist than some of my colleagues.
I think as we get older, we all get a little more conservative. Dr. Porter, do you have anything to add?
Well, I would say that for patients that end up having brain tumors as the provocateur of their seizures, I tend to think in 2 different camps. If the tumor is a benign tumor, like a meningioma, or a low-grade tumor, what we call grade 1, like ganglioneuroma, those sorts of tumors, typically those patients will have surgery, and surgery can actually cure their seizure disorder. For that class of patients, I often leave them on their anti-seizure medication for several months, up to a year, and then slowly wean them off. And that's assuming that their MRI is clear, there's no evidence of tumor regrowth or anything like that. I explain to them that their risk of having a seizure is not 0, because we know there's scar tissue that can be left behind. Nevertheless, that's a group of patients that typically the anti-seizure medications are time limited. For patients who have malignant brain tumors, so maybe they had a seizure and we found an astrocytoma, that's the type of patient that I'm more likely to leave on their anti-seizure medications, because as wonderful as neurosurgeons are at being able to take out as much of the tumor that they're able to see based on the location, we know that there are microscopic bits that are often left behind because these are diffuse tumors. And we know that when that is the case, that there's still a higher likelihood of patients having seizures even after their surgery. And so that would be a population of patients that I may leave on longer. I saw there was a patient in the chat who mentioned that they'd had an astrocytoma diagnosed over 35 years ago, and they've done very, very well. And that is awesome. I love to hear those stories. And there's always the circumstance where we have to have a discussion. Do we want to try to come off the medications or do we not? And long-term survivors. And there comes a little bit of risk with that. Sometimes I will use an EEG to help try to influence that decision. It also depends on what type of seizures a patient has. Sometimes, if they're just sensory seizures where patients will experience numbness and tingling, and there's nothing that impairs their level of awareness or their ability to safely operate a motor vehicle, that's a different scenario than someone who's having convulsions and a lapse in consciousness. And so I would say that every circumstance really deserves to be deliberated about on its own merit. And so that way we can come up with a plan together of what will keep the patient healthy and safe.
So here's a question from Vicky. Our daughter survived encephalitis, meningitis, and refractory status epilepticus. Unfortunately, not an uncommon scenario. She's not a candidate for surgery, nor RNS. She's on 4 medications and has an average of 1 seizure every 18 hours. Any other treatments that we haven't checked into?
So that's always difficult, and I express my appreciation for what this family must have to deal with in terms of a seizure every 18 hours. And I think we have the patients in the monitoring unit, we can see the magnitude that this affects the entire family. It's not just treating one individual, you're treating a network of people, including maybe a caregiver outside the home as well. So I certainly appreciate what they've gone through. I think this is where we tend at our institution to call it a comprehensive and multidisciplinary evaluation, beginning with neuroimaging, which, depending on the needs of the patient, may need to be conducted under general anesthesia. Bring them in the monitoring unit. Do they have multifocal seizures? Do they have Lennox-Gastaut syndrome? Do they have focal seizures confined to one hemisphere? Do they have an abnormal neurologic examination that suggests one particular area of the brain's involved? Then try to deliberate as a conference to decide what treatment options are they a candidate for. And it depends a lot on the type of seizure disorder they have. Patients who have multifocal seizures may be different than those who have localization-related seizures from one area versus Lennox-Gastaut, et cetera. And there now are several different options. And Dr. Elaine Worrell, our pediatric epileptologist, who's outstanding, will point out that we always have to pause and say, do we need to look at diet therapy with ketogenic diet? Many patients may benefit from that, or low glycemic index diet. Do they need to have genetic studies, even though the history suggests meningoencephalitis? Could there be other variables that might be important in terms of the response to therapy? And then with neuromodulation, you do have the choice now of deep brain stimulation, which has been approved by the FDA for focal epilepsy. We now are targeting different thalamic nuclei in the brain in these patients who might be candidates for deep brain stimulation, because some may benefit from different structures in the thalamus being stimulated to reduce seizure activity. And, I think as best you can, what you should try to do in many of these patients is palliation, reduce seizure activity. And we do know from the studies that have been done on neuromodulation that if you can reduce seizure activity, you do improve quality of life and you do reduce the risk of sudden unexplained death in epilepsy. So you don't have to be seizure-free to benefit from some of these therapies. And make certain that they're not being over-medicated. 4 medicines always sounds heroic, but there may be very little benefit and there may be adverse effects that might be significant, both in terms of the cost effectiveness and the quality of life of the individual. So these are very hard to come up with one single answer, but I certainly would try to do something to improve the quality of life of that patient.
Thank you. And I think it's really important for people. I find I work with the Epilepsy Foundation, where I'm the chief medical officer, and I find it is so common, even when people have found the Epilepsy Foundation, that they have not found an epileptologist and don't know what an epileptologist is. So for those of you, I presume most of you do, but just in case, neurologists these days should be taking care of people with well-controlled seizure disorders and epilepsy. But if there are complicated cases, then they should be seen by people who do nothing but see people with epilepsy and have a much deeper understanding of what the various alternatives are, what the new medications are, how to use them, how to combine medications. And those people are called epileptologists. And that's what...
And Jackie, there's such a gap, and I know we're going to be running out of time soon, but right now, the gap is between the needs of the patient and the available resources. And it's not uncommon for patients to continue to work with us, and I'm sure Dr. French as well, Dr. Porter, that they can't find a person in their community to see, or the next appointment is 6 months to a year out. We were told to get a blood test in 3 months because we're on this medication. It's important to check our liver enzymes. It's a really unfortunate aspect of care. And so many times we're using telemedicine or patient portals, trying to do the best we can. But we see patients from all 50 states at the Mayo Clinic. Part of that is not because we're anxious to see patients from all 50 states, it's because they're having difficulty connecting with a local healthcare provider.
So Pete has asked a couple of questions about nocturnal seizures in terms of can you give a rescue medicine for nocturnal seizures? And what is the likelihood of SUDEP in nocturnal seizures? So maybe Dr. Cascino.
Yeah, I worry about that. And I think it depends a little bit on the frequency and the type of seizure sort of that the patient has and the duration of the seizure. But, there's been a concern that patients who have nocturnal tonic-clonic seizures, if you will, a grand mal seizure, that's prolonged, that these patients may be at higher risk of having certain complications, aspiration, physical injury, shoulder trauma, and maybe sudden unexplained death and epilepsy. So it may be necessary to try to minimize seizure activity as best we can. You're right. If the patient's not alarming someone else in the house, how do you know that they had a seizure? In some instances, we've gone ahead and done in-home video EEG monitoring to get some idea as to the frequency or quantification of seizure discharges or seizure activity over several days. And unbeknownst to the family, they're having multiple seizures, not just tonic-clonic, but also focal impaired awareness seizures that were not obvious to family members. That might be a need to increase their maintenance therapy, change their medical therapy, or change their strategy. If it ain't working, why continue it? It's amazing. It's like Einstein says, if it doesn't work, why keep on doing it over and over again? And that happens for 20 years in some of these patients. So I would try as best you can. I think rescue medicine can be used if you know the patient's having a tonic-clonic seizure. I usually have a period of like 2 minutes or longer or a cluster of seizures. Sometimes we'll use a nocturnal dose of a benzodiazepine, which might help if they're really prone to those seizures and status epilepticus and prolonged seizure at night during sleep. We have patients who use monitors to try to identify any seizure activity or wearables that might be helpful. And one of our colleagues, Ben Brinkman, is very interested in wearables. But these are all things you can try to do. You need a diagnosis in those patients to decide how best to manage them, though.
So there's a website that I will tell anybody who wants to find out about devices that can be worn to alert you about seizures. The Danny Did Foundation, if you Google the Danny Did Foundation, they have every device and what it does and its pros and cons on their website, and you can take a look there. And unfortunately, as happens so quickly in these events, we have run out of time with so many good questions remaining. But before we say goodbye, I want to thank you all once again for being such an amazing audience. And I see in the chat that there are some people who have found each other and hopefully can talk to each other about the dire situation that their loved ones are finding themselves in. We host free webinars regularly, and we would really, really love to see you again. Our next event is on March 25th, Neurological Healthcare Disparities, and we will be very, very happy to welcome Bruce Obviaggi from NYU, who is the recipient of this year's Scientific Breakthrough Award. And with that, I will thank you very much and wish you a wonderful good night.
Thank you.
Thank our two panelists who have done an absolutely amazing job. Thank you so much.
Thank you.